happy to welcome Dr. Abeer because I've been looking forward to see what she's going to show us as well. So Dr. Abeer, are you with us?
Yes, I'm here. How are
Hello.
you? Hello,
Nice
everyone.
to meet you. So Dr. Abeer, Sharafuddin, she came all the way from Yemen. I've managed to take a look a little bit about your profile, but what I've learned is that she has very rich academic and clinical career. She managed to start her own practice. She worked in her own with her own team for a while. Then she started working in Queen Arma University as a lecturer as well. So, and currently I heard that you're doing your PhD in Cairo. Is that right?
Yeah, right. Yeah.
You're currently in Egypt?
Yes.
Wonderful. How are
Exactly.
things there?
Sorry, could say it again.
How are things there?
Everything is okay. Everything is going well, especially we are in quarantine.
Oh, I can imagine. It's a hard time everywhere.
Yeah.
Okay.
Yeah.
I'm not gonna take more for your time. I'm gonna let you're gonna present us the role of the soft tissue. So we're gonna talk a little bit more about the soft tissue management and about recessions.
Yes.
Okay.
Should I share my screen?
Floor is yours. You can share the screen straight away.
Okay. Thank you so much. Hello, everyone. Thank you, Dr. Victoria, for the long introduction. I'm so glad to hear that. My topic is going to be the powerful role of soft tissue graft in gingival recession. But actually, before I start, I have to mention that this is not the first time I participate in BIRD, in the British Academy of Implant and Restorative Dentistry. I had the honor to be a speaker in the implant diploma in Yemen in 2017, and it was the beginning of several diplomas there in different dentistry fields, such as endodontic, orthodontic, and aesthetic diploma. And from there, and from this point, I would like to extend my sincere appreciation to Dr. Solang Sphere, Dr. Hassan Mughaira, Dr. Tamer Deeb, Dr. Victoria, Ivan Shiva, Dr. Mohammed Al-Badani, and Dr. Wajdi Isrouri for all efforts exerted for the success of such fruitful events for diploma in Yemen. So going back to my topic, which is about gingival recession and how we can manage such cases. Because it's a common defect in the soft tissue, I have to go through a small definition, and we have to know the causes of this recession and how we can manage such problem. As we know, the gingival recession in a spatial definition, it's a apical shift of the gingival margin causing exposure of the root surface of the tooth. The causes, the first cause is the periodontitis, and the second cause is orthodontic treatment, but we can consider it as an etiological factor also. It's not a causative factor by the first priority. And also the faulty teeth brush with some patients and some persons who are obsessed with frequently teeth brushing in the wrong directions, and also tongue piercing. It causes sometimes a teeth recession or a gum recession, especially from the lingual side, and chewing gum. Unfortunately, we have this habit in Yemen and in some African countries like Ethiopia, Somalia. Okay, so before I go through my presentation, we have to know what are the different parts of gingiva. What is the frequently recessed part of the gingiva? And I have to concern about. The gingiva is containing from a free gingiva and interdental papilla and free gingiva, the keratinized gingiva or keratinized tissue, and the mucogingival junction, and then the mucosa or alveolar mucosa. Here, I'm speaking about the keratinized gingiva. And here is the problem is always happened in the side of the periodontium. So when I'm going to talk about the attached gingiva, it is very, very important, as we can know, because it's improving the aesthetic, and it's also giving the soft tissue the maximum stability during mastication. And also it's preventing plaque accumulation and mucosal recession and pre-implant inflammation. So from this point, I have to know what is the average of the length of keratinized gingiva, the vertical length, I mean here. I have no stable length. I have no stable width measurement. So I have here, we can imagine that keratinized gingiva could be reached to 7-12 millimeter, sometimes 3 millimeter, and 1 to 2 millimeter. And guess or not, sometimes I have no keratinized gingiva. Here, I have to interfere, I have to augment, and I have to make a surgical performance. Okay, some cases and some reports were performed by a lot of doctors, a lot of authors, trying to augment this critical and this significant side of periodontium. Some authors used the collagen matrix to augment the side, and some of them used the, as we can say, the apical reposition flap to increase the width of the keratinized gingiva. And some of them used the free gingival graft, and some also used the leukocytes platelet-rich fibrin, but in multi-layers to create such tissue. I'm going now in some presentations related to my cases. Okay, I have done them in the Cairo University, supervised by several doctors whom I'm proud of them. The first case is going to be the connective tissue graft with coronal advancement flap. This patient, Summer, came complaining, she's complaining from recession in lower incisor, central incisor with thin tissue biotype. When I made the periapical X-ray, also as a periodontist, I have to make periapical X-ray in every case, in every recessed case, because every periapical X-ray, it's really revealing the level of the crystal bone level and the interproximal bone level. So the level of the bone is telling me that do not expect full root coverage if there is a root bone resorption. Like in this case, we can classify it as a class RT2 according to Cairo et al. Classifications, which is the new classification. This case, I cannot expect full root coverage, but I can expect or anticipate 90%. Yeah, I will be optimistic in this side. Here we have the recession depth about, I think it's about 7 millimeter, I think. No, it's 4 millimeter with gingival thickness 1 millimeter, which is a thin biotype. We can consider it as a thin biotype, and width of keratinized gingiva, it's 1 millimeter only. So how can I deal with this case? Should I do free gingival graft? Should I do coronal advancement flap with connective tissue? My surgery based on this fabulous paper created by Cortellini, Tonetti, Piniprato, and Cairo also. They reported and concluded that I can do connective tissue graft with coronal advancement flap, even if I have only 1 millimeter width of keratinized gingiva. But in a spatial condition, if I don't have any bone resorption in the crystal bone level. So this case was so tricky for me, but I decided to go through it, okay, especially that I have here a good papilla, interdental papilla, and the patient's still young. I can get such healing, I can get such results. I started my surgery here by split thickness flap, okay, with 2 vertical releasing incisions. And then I harvested the connective tissue graft from the palate with single incision technique, avoiding patient morbidity and chair time. Here, the connective tissue graft in the place on the periosteum, on the vascular bed. The vascular bed is containing vascularization, rich with fibroblasts, rich with macrophage, rich with what else? We can growth factors also, which do the maximum rule during the healing process. And then I have here, yes, I fixed the connective tissue graft with Vicryl suture, 5-0, with crisscross suture and interrupted sutures, and then the coronal advancement with the Pluperline suture, okay? Avoid to use silk in perio surgery because silk sutures actually accumulated the plaque. This is the case after 2 weeks. After 2 weeks, I prefer to remove the sutures because sometimes in order to avoiding plaque retention and plaque accumulation. But you have to make sure first that about the fragility of the soft tissue. So you can remove the sutures, okay, you remove it, but it's still fragile, leave it as it is, and it will disappear. This case, after 18 months, we can see here the difference between the baseline and the current case. And here is the difference and the huge difference between the baseline and after a year and a half. The patient was very, very satisfied about the results. Okay, I'm going now about the second case. Please, if anyone has a question, please try to put it in the comment box and I will try to answer all the questions. The second case was about modified free gingival graft. What do I mean by modified free gingival graft? Okay, this patient has a story. She came to me complaining from the recession in the lower incisor, lower central incisor, and from the persistence inflammation. Persistence inflammation. What do I mean by persistence inflammation? The patient, before any surgical procedure, I have to prepare him or prepare her by scaling and subgingival debridement, antibiotic, mouthwashes, instructions. But unfortunately, this patient did not respond. We can say it as it's not a refractory case because the inflammation is localized, especially at this recessed tooth. So in this case, I decide to jump to another solution. It was, I have to change the tissue as a complete whole of tissue. I have to change it, qualitative and quantitative changes. The tissue here was the keratinized tissue, keratinized, and width of keratinized tissue was 3 millimeter, and the recession was 3 millimeter also. So I have here a good keratinized tissue. I can only advance the flap, or I can also make a connective tissue graft with coronal advancement flap, like the previous case. But when I discussed this case with my supervisor, he said, okay, he agreed with me and told me that you can do what you want about the changing of the qualitative, the whole qualitative and quantitative changing of the tissue. Here the tissue about 3 millimeter, as I said, and the periapical X-ray revealing soft tissue, the hard tissue resorption, okay? So again and again, I cannot anticipate the full root coverage. My surgical performance based on an article published by Dr. Hani Nahas, who I proud of him because he was my supervisor, and also I did the surgery under his supervision. Firstly, I did the tunneling technique, started with incision by Lancet 15C intracellular, and then I continued the tunneling technique with the tunneling knife until I exceeding the mucogingival junction. Here, of course, the papilla is still attached at its place. Then I got the donor side from the palate, which is the free gingival graft. This is the outline of the free gingival graft. And then I harvested it. Okay. The thickness of the free gingival graft should not be less than 1.5 millimeter. I tell you why. And I started to make a deepithization. Why do I make deepithization? Here I tried to give you a homemade illustration to explain what I did in the surgery. Suppose that in the left side, I have a free gingival graft. Okay, then after harvesting, I make deepithization. The all part of connective tissue, I deepithized all the underlining parts, and I left only the coronal part, which is the epithelium, which is the part is going to be exposed in the oral cavity. Like here. After I finished the tunneling technique, I embedded the tissue, the connective tissue inside the pouch, and then fix it with internal horizontal mattress with the vicryl sutures. And then I made sling suture and interrupted suture. Here, I left the epithelium, only the epithelium is exposed because I decided previously to change the all tissue, qualitative and quantitative changing. After 12 months later, you can see the difference. Here, the different situation, it's not, there's no complete root coverage or 100 complete root coverage, but we can say it's 18% root coverage and the persistence inflammation disappeared. And this is the result. This is the exactly results I want to reach to. This is the second case of me. And the third case, I'm going to speak about the free gingival graft with coronal advancement flap. I mean here the surgery named as a second steps or two-step surgery. This patient was very satisfied about herself after the surgery because at the beginning she asked me to, and she insisted to go through this surgery. As we can see here, she has a terrible recession, okay? And also she is complaining from the sensitivity and she can't do anything from this situation. The recession here is about 7 millimeter, and of course we have no keratinized gingiva. The periapical X-ray revealing a very resorbed alveolar bone. So also I cannot expect complete root coverage. Yes. My surgery here based on the article published by Dr. Cortellini, Giovanni Cortellini. He concluded that we can do free gingival graft at first to augment the keratinized gingiva. And then after that, we can, after 3 months, at least after 3 months, we can do the other step, which is the coronal advancement flap to get the complete root coverage. Here I started by recipient bed, which is a split thickness flap. I mean here by split thickness flap is exposure only to the periosteum, not reaching to the alveolar bone. The donor side was the palatal side. From the palatal side, free gingival graft is here. This is the dimension of free gingival graft. And then I put it in the vascular bed with horizontal crisscross interhorizontal mattress. with Vicryl sutures, and I left them like about 2 weeks later. I got here a keratinized tissue. Okay, the result was good. And here 5 months later. As we can see here, after 5 months later, the tissue, the soft tissue healing actually takes a long time, because to reach the point of complete maturation, complete orientation, and complete integrity, because the connective tissue or the soft tissue graft are they are going to a creeping and shrinkage stages. So I have to wait for such stage, for such step, and then starting with another surgery after the soft tissue takes its time. Here, the width of keratinized gingiva, okay, I got 5 millimeter. So the patient is ready for the second step. The coronal advancement flap after 5 months, starting the second step. Okay, this is again the split thickness flap, exposed only the periosteum. And after that, I made the sutures after I advanced the flap to belong beyond the cemento-enamel junction. Okay, and I fixed the flap with the sling sutures and interrupted sutures at the vertical releasing incisions. And this is 1 week after surgery. Here 2 weeks later. And this results after 1 year. Here, I want to say something. The patient, you should instruct the patient, do not brush her teeth. Do not eat anything as sour foods or flavors or something like that, because it will interfere with the surgery. Eventually, this is the baseline of the surgery, and 5 months later and 12 months, the patient was very, very satisfied, and she was happy for of the surgery. This is what I want to participate today. And take-home message is, do not hesitate and follow your passion. Always, always follow your passion and be optimistic. Thank you so much, and stay safe.
Thank you very much, Dr. Abeer. Very nice, straight to the point presentation. So well done, and obviously to have one of our proud members of Bird Academy in Yemen, this is a great pleasure to have you here.
Thank you, sir.
All the respect goes to our good friends in Yemen, despite the tough times Yemen going through. Bird Academy never stopped.
Yes.
And Dr. Wajdi, with the great support of Dr. Muhammad al-Ba'dani and all the great team and yourself, done a great job.